Hello everyone, welcome to another edition of Cosmetic Corner. My name is Surek, your moderator, and I'm very excited to have Dr. James Zins as our expert discussant. This is his second time on Cosmetic Corner. As you all know, Dr. Zins is the facial surgery section editor for ASJ. He's also the chairman of plastic surgery at Cleveland Clinic. Dr. Zins, thank you so much for joining us today.
Well, Chris, thanks for having me. It's great to be here.
Awesome. We're here to talk about a great article looking at PRP. This is from Dr. Gino Rigatti and his research team in Italy. What they did in this study is that they wanted to look at the effect that PRP had on the skin and the mastoid region, looking specifically at changes in the dermis, in collagen deposition, as well as fibrosis. This is to piggyback upon earlier work they did looking at stromal vascular fraction and fat grafting. I think it was an excellent article. I think it had a lot of interesting scientific methodology to try and standardize this, although I do think there are some limitations, which we'll get to discuss here. The article was complemented by a very nice commentary by Dr. Austin, and he pointed out some of the limitations of the study as well as gave some nice compliments. One of the limitations that I did see is that the fact that the 3-month post-injection biopsy was taken very near the initial biopsy could indicate that some of the fibrotic changes they saw on the skin could be related to purely the response from healing of the initial biopsy site. So Dr. Zins, let's jump right in and kind of talk about this article. You did a very nice review article recently in ASJ on PRP. And tell me, what do you think the authors did right in this study, and what do you think we still need to expand upon here?
Well, Chris, yeah, I agree. First of all, I think Dr. Rigatti and his team deserve a lot of credit and congratulations. As you said, this is just one of several studies which they've done looking at means of enhancing wound healing and fat take in the clinical situation and research situation. So I think they deserve a lot of credit. I think basically what we're looking at here is an attempt to find an economic way of enhancing wound healing. What they were able to do, as you suggested in their previous work, is they used adipose-derived stem cells and the stromal-enriched component of that to enhance wound healing, and they demonstrated this indeed was effective. What they were next moved on to was to try to use platelet-rich plasma. Now, the beauty of platelet-rich plasma is that it's very economical, it's extremely easy to produce clinically, so that is the plus side of it. The negative side of it is that most of the data that has been generated is soft data at best, both on the clinical and the research side. So, to get the long-winded answer to your question, what they did well was they tried to document what the platelet-rich plasma they were using, how it was made, how it was composed, and they did a pretty good job of in doing that. The only problem that I saw, and I reread the article again before this interview, I couldn't find how if they measured platelet concentration either in the patient, in the pre-treatment blood, or in the platelet-rich plasma enhanced blood. So this, I think, is a problem, and this is a problem that we see as we go throughout the literature with PRP. Again, if we don't know what the component is, we really can't calculate a dose-response curve. The literature has shown that we need at least 1 million platelets per cc for PRP to be effective. So I think that was one major issue that needs to be clarified. In our review article, we coined a term called FitPaw, and this FitPaw was done to look at the filtration, the means of filtration, the number of spins that the platelet-rich plasma was concentrated, the time of the platelet-rich plasma concentration, and most importantly, the platelet count both before and after PRP fabrication, and then finally whether an anticoagulant was used, and then whether white cells were present or not present in the component. All of these things, all these variables affect the efficacy of the platelet-rich plasma. So this is a complex issue. The other thing is, of course, wound healing is extremely complex, and taking a look at one point in time at 3 months also I think is an issue. Clinically, most of us are using PRP. What we're doing is we're using multiple treatments, treatments that perhaps 1 month apart for 3 treatments, for example, if we're using platelet-rich plasma for hair restoration. So I think this is a good start. This is what we need to do. But what we need to do is we need to produce a consistent product. pH affects this, white cells affect this, lots and lots of variables here. And again, the white cell, they said that this was white cell poor, although that really wasn't documented as well. So the finding, and again, getting to the point, the issue with the study was that they were unable to show that platelet-rich plasma was efficacious in a similar way that the adipose-derived stem cell platelet-rich, their stromal-rich fraction was effective. So it was not effective. They intimated that this was due to fibrosis and basically scarring. This could be affected by white cells, this could be affected by pH, this could be affected by a number of variables. So what we need to do as we go forward is we need to be able to produce a consistent product, and we need to also have patient outcomes detailed. And I think those are two really important things.
That's an excellent summary, Dr. Zins. That sums it up pretty well.
Pretty long-winded.
But that's actually a very great detailed response. You know, one last question. I know that here at the Cleveland Clinic, you've been doing some initial work with PRP. You've done some in the past. Now you've kind of regenerated that here now. Tell me a little bit anecdotally about your early experience with PRP and what your vision is within your own institution as how you can continue to contribute to the literature.
I think that's a great question, Chris, and I would make a plea that really what we need to do is, in addition to designing a consistent product, we have to have consistent patient-reported outcomes using such vehicles as the FACE-Q to document the efficacy of this from a clinical standpoint. Anecdotal reporting is no longer adequate in the scientific literature. So I, again, would make a plea to our researchers and our clinicians that we use validated patient-reported outcomes as we go forward. That being said, what you're asking me about is anecdotal information. And anecdotally, what we saw was when we were using this in our facelift patients was less swelling, less bruising, although we did not document this in an objective fashion. We're also using this now for an attempt for hair restoration. And again, initial results are good, but we need to objectify our findings, and we need to do this both from an objective standpoint and also from a patient-reported outcome standpoint.
Excellent. Well, Dr. Zins, thank you so much for joining us.
Chris, thanks for having me. It was a pleasure.
It was an honor. See you next time.